Hello and welcome back to the Evolution of Medicine News Videocast. I'm your host, James Maskell, and this week we are back for Charting the Convergence with John Weeks. And I also have here in the studio my partner, Gabe Hoffman. As ever, welcome back.
Hey, James, good to be back.
And John, great to have you back on our third Charting the Convergence. Very excited for this to have you back on the show.
Pleasure to be here with you too again.
So we always have a sponsor on the show, and again, this week our sponsor is a little bit different than normal. It's a big announcement for our community that we are going to be running building a functional medicine membership-based practice course in this July in Salt Lake City. For those of you who remember last year's summit, we brought to the world Liberty Direct, the first affordable alternative to health insurance, and now many clinics are setting themselves up to be able to take that affordable alternative to health insurance via the direct primary care membership payment. And so this is a save the date to people who are interested in that. It's going to be coming to you the 29th and 30th of July 2016. So save the date on that, and that's something that's going to be coming up soon. So welcome to this episode. So we've got a few interesting pieces that John has picked out this week, and we're going to start with something from healthcare.gov. Now, John was really someone who schooled me about how insurance in America worked. I thought for the first time, I was under the assumption that insurance carriers had incentives to cut cost, and you were one who schooled me on that. So take us through the 80-20 rule and how it might impact our community.
Very good. It's a pleasure to have the chance to provide this education. We all sort of stumbled on it, learned it the hard way on the streets when we assumed that our approaches, which we assumed would be less expensive than regular care, weren't getting the attention that we thought they deserved. And here's the bottom line, is that in our system, the administration and profit of an insurance company is anticipated to take up to 20%. 20 years ago, it was up to 30% of the premium dollar. So if you consider it at 20% and say, okay, a family's premium is $1,000 a year, then the insurer has what, $200 to play with for their overhead and their profit. Now let's say, as has happened over the last 25 years, that premium's up at more like $8,000 to $9,000. Well, at $8,000, you've suddenly got $1,600 that's going to come to profit and administration. So the question is, is it your interest as an insurer to keep costs down and to drive them further down to say $500, premium? And the answer, of course, is no, because then you're getting 20% of $500. So we have this odd reality where an insurer, within a premium year, be incented to try to keep things less expensive. But overall, they actually see more revenue and see more profit the more everything costs.
Gabe, you and I spoke about this just after John schooled us a few months ago about this, and it's pretty depressing in a certain way to see this. I always think of cost plus type of arrangements, almost like the war in Iraq, right? And that's how you end up with a $10,000 toilet because someone's getting 20% on top of it, and it's kind of horrifying to see this in American medicine, but at the same time makes sense of how we've got to being the most expensive healthcare in the world so quickly.
Yeah, I guess maybe it was a little bit naive to have thought that the system was built any other way. And it would have been, I guess also we would have seen a lot more movement and maybe support if something as large as insurance had that level of what we thought motivation to cut costs, right? Because it would have been obvious that they would have been all over what this movement is about. And I guess, yeah, like when you hear it and then you learn it everything makes a lot more sense, although it is a little bit, I don't know, deflating, but it's not exciting to hear that that's the way it's built. I'll say that.
John, I'd just like to get your thoughts, because I've lived in the UK, obviously, where you have a central single payer, and then, when the taxpayer is paying the bill rather than it seems as though other countries have better incentives in this regard.
It's definitely a kind of a nasty incentive to benefit from things getting worse. ultimately, for folks like ourselves who are bringing a different model forward, we've still got to get on the agenda of whomever is in charge of making the decisions and get them to choose to want to do the kind of research that would explore whether or not these services do reduce costs, like they're doing, for instance, at the Cleveland Clinic. We've talked about looking at the whole kind of black box of what you do in an integrative setup. But I think absolutely, and the data are there. A single payer does create better health at lower costs. There are some downsides to it. But, in that case, it would be incumbent upon all of us to make friends in government to help them decide to explore what our services could mean. I know that in Canada there's been, there's still challenges, but where they've got a single payer, you do see more direct governmental involvement there than we did down here at a deeper level.
Absolutely. And this is an interesting story, but I think over time what you'll see is that more people will have incentives to cut costs. Right now, you don't see as many actors having that, but certainly businesses, especially self-pay and self-insured businesses, now have these incentives. People really have these incentives, the individuals, to reduce costs. And soon, I think, payer systems will as well. Healthcare was 18.8% of GDP in America this year. We'll see how high that can go before there are incentives to cut costs. And just know that when it does happen, we're going to be in a great position to, to take advantage of that. So thanks so much for sharing that. Now, the next story, John, we're going to talk about something from the Minnesota Department of Health, talking about creating health equity in Minnesota. And before I let you loose on this topic, I thought this is just a great time to bring up the fact that, on the panel that we did at Integrated Health Symposium, Jamie Harvey was one of the speakers, and he's from Minnesota. And just as a preview for everyone, on Monday, the 2nd of May, which is coming up this Monday, we will have Jamie Harvey's talk from the community health panel that we did there as part of it. And John, I'm sure because you chose Jamie, I just think you know him probably better than anyone on this in this community. Just maybe just. I'd love to get your thoughts on, his work and how it fits into this determinant of health graph.
Well, pleased to share. Jamie's been truly out front in and looking at the broader systemic root causes around what all the contributors are to health. He actually made his first national name for himself as taking the lead in getting mercury out of the hospitals and looking at hospital waste, which itself was a major toxins, and getting handling around that. He's then moved into this whole area of the health commons, which is a much broader view than the clinical view. And we had a nice dialogue on this in New York, as you may recall. This chart came to my mind, and I sent it to you because I just came back from DC, where at what was the Institute of Medicine, now the Health and Medicine Division of the National Academies, we were reviewing a recent report there on the social determinants of health. And I thought that this was an interesting thing. I'd like to get your response, because as you look at this, the clinical care and its contributor to the health of a population, is imagined to be just 10% here, and viewed as that of all of the factors on a population's health. If we actually look at what our integrative practitioners do, which is different than regular, care delivery, you sort of move into that health behaviors section. And so you can actually be expanding your role in dealing with these determinants. But the question I put to you and Gabe is that the people writing about this and about this change of mind to kind of get out of the idea that clinical care is everything, to realize it's actually a small player, as they speak about these other causes: education, poverty, access to food, zip code, as root causes in health. And I know you, of course, view what you're promoting here as root cause medicine. So I'm wondering how you see the two interacting.
Gabe, I'd love to throw this over to you because I know we talk about this a lot. I'm happy to weigh in, but I'd love to get your thoughts on this.
Well, yeah, there's a lot of interesting things in this graph, and when you look at the social and economic factors, you could see that those are actually influencing the health behaviors. I think part of what they're describing is who you grow up around and what you're exposed to is going to impact the choices you make. So that 70% really feeds off itself, and I think it's important too to break up the social and economic factors, because you've got some of it that can feel very disempowering. This is where you are, this is where you were born into, and now that's as bad as basically saying your genetics dictate it. So we want to look at, and it's important to look at. So we know health behaviors are important, but I just am really fascinated by the idea of how do we get into the areas where social and economic limitations have changed what people were exposed to and expose those people to the type of healthcare and just self-care concepts that aren't fancy clinical procedures, but are basically just basic parts of self-care that maybe we, us in this more privileged part of the world are aware of. And maybe that's a way to get a big chunk of this 70% to approach it that way. So that was one of the first things I was thinking about, James.
Yeah, I think that's a great point. And I think this is one of the reasons why I'm so excited about, the work that we're doing now to be able to make functional integrated medicine more accessible to more people and bring down the cost through improving efficiency and so forth. Because, it does take, obviously if you're seeing a provider that can help to influence health behaviors, that's good 30%. But in order to make these types of approaches available to the middle of the bell curve, it has to be affordable. And that's one of the reasons why I'm excited about things like Liberty Direct and the sponsor of this week's show, or the Save the Date, is because I've seen already practices like Liberty Direct will pay your direct primary care payment up to $60 to $100, depending on if you're a patient, through to a family. And so you can see that there are ways that we can create affordable solutions to get people in front of the types of providers that can help with all the rest of the types of things. So I think we talk about fighting over bits of the pie. Here's the pie right now, and there's 40% of people who have no way of engaging with any sort of integrative functional medicine right now. And I think that if we can get the model right, where it's efficient, where we're using different types of providers, I think there's an opportunity for the pie to just be that much bigger, and for anyone who really wants to make a living delivering this kind of care, which is so soul affirming, to be able to do so.
Yeah, I'd just like to say, I think we're in the context of the convergence. A lot of the mainstream folks who are working with this chart are, they're comfortable believing that clinical care is just a 10% pie. And so part of our work is to actually get them to realize that an integrative or functional model really, if it's at the base of the clinical care system, then you actually are picking up and moving into the health behaviors. So that's a part of our work. The other piece of it is, I think, looking internally and realizing, okay, how can we make sure we are addressing those social determinants and other determinants of health? For instance, are we going out into people's homes and checking on the level of toxins that they may be living with in a regular way? Are we paying enough attention to family and system? Are we drilling into, because our people tend to have better incomes, the income issue is not the biggest one. But there are other factors that if we don't view our holism with a broad enough perspective, we won't be able to penetrate as well into those other social determinants.
Absolutely, yeah. Well, I think this is a great graph, John, and really appreciate everyone who's working on these kinds of questions. I think is some of the biggest work that we have to do. But I think as a community, one of the most important things we have to do is just really improve efficiency, create an opportunity for doctors to make as much money, if not more, than primary care or being a family doctor, so that there's the right incentives to come across and practice this kind of care. But also, some of the models that we're seeing now, things like group visits, where you can really make this affordable to everyone, and you can use the power of peer-to-peer community support and sort of access that in a clinical setting. I think those are all the things that we need to be focusing on. So the third article that we're going to bring up today, I know everyone loves lists, and recently John posted on the Integrative Practitioner blog 10 years of integrative medicine. It was the top 12 stories from 2006 to 2016 about really the last decade and what things have what's been happening that's been the most important. Now, John, I'd love to just get your thoughts. I mean, we probably don't have time to go through all 12, but I would really recommend everyone to check out this article, and we'll have it posted in the comments below, either on Facebook or on YouTube. If you're listening to it on audio, come and check us out on YouTube, facebook.com/functional forum, where you'll find it. But John, out of all these 12, if we're looking at the convergence, right, this grand convergence of the new medicine, the old medicine, the payer system, technology, all these things arriving, all the different providers arriving to sort of show the way towards a more effective way of dealing with chronic disease. Are there some that jump out to you as sort of like the most important in the last decade?
Sure, and just to be clear, these were based on my own navel gazing at the Integrator Blog. I was looking at, I celebrated my 10 years, and so looked at what I'd published by page views, and this is what we came up with. At the top, I actually think that it is important that the integrative MDs end up having a clear brand over time, and so there's this fellowship. And it's the way you gather power, gather influence in the regular medical community. And that's where most of the money and most of the clout is taking place. To have a standard there is important. And that's the strategic shift. Originally, Andy Weil and his program really were about integrating all of medicine. And they got to a certain point where their fellows said, you know what, we want to be able to distinguish ourselves from somebody else who might self-declare as integrative, and started this fellowship. So I think in the long run, having that standard has been huge. Another just major area that a lot of people pay a lot of attention to, that's a sign of division rather than convergence, but it's this area of the scope of practice partnership of the AMA that still continues to restrict our ability to converge. This is an AMA-led effort, started in 2005, 2006, and it's really focused on just old style politics. Let's stop nurses, optometrists, naturopaths, chiropractors, acupuncturists, whomever, from expanding their scopes or creating new licensing in new states. And it's not evidence based on value. It's based on old style silos. Big story, continues to act. We can't see the convergence as long as they're in the driver's seat with that kind of work. There is something called the Coalition for Patients' Rights that was set up as a group of these professions that have been fighting against it over time. So there's something in place there, but a big story that continues. I think the third that I'd pull out would be number 6 here, and it's really linked to the success of integrative practitioners in getting into federal law with the Affordable Care Act, and specifically this non-discrimination clause coming in. It directly, of course, attacks what I was just speaking to, which is the level of discrimination that continues. The more that we can come together and elevate, again, it's language in the law. It requires our proactivity to make sure that insurers in a given state live by it. But it's created a context and a possibility under federal law to allow deeper convergence. It's hard for a medical doctor often to refer to a practitioner who's not covered in a given situation. It just causes a different kind of mindset, different kinds of administration. So it's critical, this development, and that IHPC has been taking the lead in. I invite you to go to Integrative Healthcare Policy Health Policy Consortium, ihpc.org is where they work from.
John, let me ask you a question. As you went through the process of sort of seeing which articles had the most, reads and how you set up this list, did anything stick out? I mean, you've been at this for 10 years. Obviously, you're all over what's going on in the industry, and just did anything stick out in terms of what had the biggest buzz, like how you ended up with this list? And you see any common themes or anything in here that sticks out? I think it's interesting.
Thanks. One of the most interesting things was that a number of the comment forums. So I've done this often through the years, where it's kind of old media, where people would send me some comments, then I'd post it with a little bit about them with their picture. So it's a little different than just a comment forum on in a blog post. So it's a little bit more personality, because I was working on integrating people from different fields. And there was a lot of interest shown many times in their comments. For instance, under the strategic shift, there were 2 very, very well-read forums of people talking about that shift. And so people were really as interested in what each other had to say. And I think it was particularly meaningful because I've intentionally worked to aggregate an interprofessional group. It's not just MDs or chiropractors or naturopathic doctors. It was a place where you could go in and hear somebody from another discipline who was in a leadership role often talk about the issue. That was one of the most significant ones. This like number 11 there, that this, the role of the AMA, and that's still that shadow of the AMA, and concern about what they of the negative AMA. The AMA does some good work, but can definitely just be working as a warrior to protect. And so this fact that they, AMA owns the CPT codes that folks are required to use, and therefore makes money off of everybody that uses it, is another big one. So that we still, though we're positive focused in philosophy, we still respond to negative threat and read about it.
Absolutely. Well, look, John, I really appreciate you taking time to bring this together, and, just to be able to, have some context for all of our community. I mean, I think that, we just launched our accelerator last week for doctors, and one of the most exciting thing, or for practitioners, one of the most exciting things is just seeing how many MDs, who are switching practices right now. We're very, very excited the fact that, our community, I think more than anything else, has been able to sort of galvanize or make it a little bit easier for MDs to leave family practice and come into the integrative world. Gabe and I, right from the beginning, we didn't want to just preach to the choir. We wanted to build the church, and it's exciting to see individual doctors, making that shift across, and also, as a bigger community, everyone starting to realize that this is the future of medicine. It's very exciting for us all to, to be part of it and to be living this in real time. What do you think, Gabe?
Yeah, I mean, absolutely. This is, it's just, I appreciate learning more about the people who have set the stage for what we're part of now. And I really respect that. And I always find it interesting when we have John on as a result, because he, without all these, this convergence and all these movings and acronyms and different people coming together and dialoguing. I mean, this was the community that was generated. And even like John said, what created the number one, it had to do with a conversation happening in the comments, which is very much, James, what we're trying to do and how we're looking to make change, which is create a conversation between like-minded people and create ways for them to get together. And it's not just about empowering the individual, it's about bringing together a community who cares about empowering each other. And I think it's, just very appreciative of whoever's been doing this work before us to put us in a position to try to take the community to the next level.
Absolutely. And John, you're a great representation of that. And so we're really excited to continue to, to have you here monthly to wrap up what's important. Any final thoughts before we wrap up for today, John?
I actually just want to honor and wish the best in your effort to, pull the sword out of the stone of how to really create thriving integrative and functional practices that hopefully in time can bridge over into new communities that we don't reach so well. So I was pleased to see you directly taking it on, and I just hope you'll have maximum creativity and in your efforts to answer the questions and to help guide the community.
Perfect. Well, thanks so much. Yeah, we were very excited about the future. We are taking it head on, and you'll see over the next few weeks, whether you're watching the forum or listening to the podcast or otherwise, it's not just the things that we're doing. We've asked a lot more of our sponsors. We're bringing together, different groups to just try and create something for everyone. There's no reason why people don't need to be successful. The best practices are emerging. One of the things I said in that accelerator sheet that I wrote about is like, this is a young industry. The best practices haven't really emerged yet. We don't really know what the best practices are, and the way that we're going to do it is we're going to crowdsource it, and it's going to be a hive mind of people bringing together, and we're happy to be in the middle of the conversation, bring it together. So thanks so much to John Weeks and Gabe Hoffman for being part of the conversation. This has been the Evolution of Medicine News Videocast. This week our Videocast has been brought to you by an amazing course that we're going to be doing the 29th and 30th of this year in Salt Lake City. If you're an MD, DO, or licensed ND, or you will run a practice with one of those providers in it, there's an opportunity to build a membership practice, and there's so many benefits to doing it. We're going to be having an announcement coming out in a couple of weeks about it, but save the date if that's something that you're interested in, because we really see this convergence of direct primary care and integrated medicine as the business model and the clinical model coming together for the future of primary care. So thanks so much for listening. I'm your host, James Maskell, and we'll see you next time.